shift will be from anti-VEGF to another anti-VEGF before we are going for the steroid, or we can move directly to the steroid, or there will be no rule for steroids anymore?
That's a really good point. I think it depends on the lens status, I'll be honest with you. If they're phakic and their diabetic macular edema doesn't respond to a first-line anti-VEGF agent, I would switch to a newer anti-VEGF agent, but I would only give a couple of injections, see that patient very closely, because what I don't want to do is for the irreversible retinal damage to kick in, because if they're not responding to that newer anti-VEGF, I want to switch to steroid at the earliest convenience. If they're a pseudophakic patient, honestly, what is the risk? What are you going to do to the eye? There is a 1 in 3 chance that you will have to give them ocular hypertensive drops. But we know with Ozurdex, the vast majority of patients, their ocular hypertension rise is manageable. And if it was a pseudophakic patient, I'd just make the switch directly. I wouldn't try a second line, because I think the benefit risk is favorable to give a steroid in that case.
Yeah, I think I agree, because we need to remember, simply those who will not respond to anti-VEGF, most probably will not respond for anti-VEGF. Except, of course, if we say faricimab is working in 2 pathways, Ang2 and the anti-VEGF pathway. However, I think the steroids will remain there, because big part of the pathophysiology of the disease is the inflammation, and this is why we need to consider
but
early switching.
Some patients may not be able to tolerate the frequency of treatment that they need with VEGF, anti-VEGF.
Yeah.
So actually, steroids are still the steroids that we have are still the long-acting agents.
Yeah, definitely, without that. But you can argue about this, because faricimab, for example, in 50% of patients, they will stay on 4 months, and 70% will stay in 3 months.
That's a good point.
But of course, the main drive, I think, in my opinion, the inflammation here. The other thing is, did you give Ozurdex for glaucoma patients or not?
It's a really good question. So I have given Ozurdex in glaucoma patients, but I would always give it as a second-line agent. So so you have a glaucoma patient. I'm treating their diabetic macular edema initially with anti-VEGF, but if I'm not getting vision improvement or anatomical improvement, at the end of the day, you can't. Once the retina is damaged, once macular ischemia or macular degeneration kicks in, you can't rescue that eye. You can't rescue that central vision. And so I could justify the risk from an Ozurdex implant in a glaucoma eye, because the vast majority, the pressure response will be manageable with drops. But on the odd occasion where I was worried that their glaucoma was brittle, I would have a conversation with my glaucoma colleague, and they would just say, look, you do what you need to do to manage the maculopathy, manage the retinopathy, I'll manage the pressure. And I can really say hand and heart, in the 13 years as a consultant, I can only think of one Ozurdex patient, and maybe only one ILUVIEN patient needing filtrating surgery. So there was going to be a lot of patients who would not benefit from steroid because I was worried about this very tiny risk.
Yeah.
At the end of the day, our job is to save retina, is to improve vision, because it makes a difference to that patient's quality of life.
I'll just echo what Fahd said just now, because simply I used it for many glaucoma patients, to be honest. I'm a retina surgeon and I'm a retina consultant as well, but that's what exactly meant to be. Yes, you can use it in glaucoma patients, because simply not every single one will be a steroid responder. That's the first of all. Second, I think the guidelines started to say if he is in 1 drop or 2 drops of glaucoma, you can still use it, because you can still have the 3rd-line treatment for glaucoma patients. I'll not consider it in someone who is already on 3 glaucoma medication, except if I have to. As Fahd said, we need always to remember that damage to the retina is irreversible. So whatever happening from the edema, if the patient is not responding, cannot return it back. But anything else with the steroids, including the pressure or the cataract, I can treat it. Okay, that's what we have to remember. Actually, I think unfortunately, we reached to the end of our talk, but if I'm going to summarize in 3 or 4 words what Fahd said, I'll just say early switch is a key because simply people keep injecting, and by the time we switch, we lose vision. Second, steroids can be used as a first line of treatment. Third, even with the new players coming to the market, I think the steroids will always have a role because simply it is part of the disease is inflammation. Thank you very much for listening.
Thank you, Ibrahim.
احمد شو رايك؟ انا والله مالي خاطر اتكلم احكي.
لا لا لا
احكي يا باشا.
لا 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 احكي.
Hello. Assalamu alaikum. Good evening, dear colleagues. We'll go to next sessions. Dr. Ayman, Dr. Fahad, we will go to next session, please. Thank you very much. Next session, it will be a medical retina session. It will be a debate. And I have with me Dr. Nazim Al-Hussein and Dr. Ahmed Al-Khasham and Dr. Muhammad Aoudallah to moderate this session. So this session, it will be a very strong, so you have to concentrate and see who's going to beat other ones. So the first one, the first presentation, Dr. Mandib, and he's going to talk about brolucizumab. Then we'll have Dr. Prasan Rao, he will talk about faricizumab. So we want to see who is going to win in this debate. So Dr. Mandib, you are there? Okay. So everyone having 5 minutes presentation. No, you can see them.
So ladies and gentlemen, a very good evening to all of you. From the onset, I would like to thank the MIOM Society and the gentleman on the dais. Thank you very much for giving us platform to share our thoughts, experiences, etc. My thoughts on this particular topic is actually pretty divisive. I think it's unfair if I'm going to put both the molecules head to head. Both are fantastic molecules. And the big thing is there is no head-to-head study as of now comparing both of them, putting them in the same tray. So we don't know which one is superior and which one is not directly. So what I'm going to do is take an indirect route, basically taking some snapshots from the previous studies which allowed these particular molecules to come to our shelves. That is comparing them with the previous molecule, Eylea or aflibercept. So what do you expect from your anti-VEGF? What is the ideal anti-VEGF? It should be a good molecule with good pharmacodynamics. It should give you a good visual acuity gain. And that should be predictable and sustainable. We all want to look at something which gives us drying capabilities, and that too with few injections. And of course, we want it to be safe. So if you look at the brolucizumab as a molecule, it's a very dynamic molecule. It has two ends. One is a hard end and the soft end. The softer end is actually a V-chain immunoglobulin, which has got a molecular weight of 26 kilodalton, and that gives a dynamicity to the whole molecule, allowing it to have good perfusion as deep as choroid and RPE layers. One interesting fact about the molecule is its serum concentration has been proven to be less than 6,000 times of that in vitreous cavity. So if you look into this particular parameter, that of aflibercept was 950 times. So we used to talk about all the systemic side effects and all. Probably we have a more safer molecule in that respect. Visual gain has been repeatedly proven by different studies. This is a snapshot from Kite and Crystal, Kingfisher. Everyone has shown that basically this molecule is non-inferior to aflibercept. And this is a snapshot from Kingfisher study. Again, it proved that this particular molecule is non-inferior to aflibercept. These responses have been predictable and sustainable. And if you look into this particular snapshot from Kite and Crystal trial again, you will see that 87% of patients who were injected with 6 milligram of brolucizumab could actually were put on quarterly injections after a loading dose after the first DA approval. So you have a kind of predictability factor when it comes to these injections. Similarly, brolucizumab 6 milligram when injected after the initial loading dose, if the DA approval was there and DA was positive, that is, they did not show an active activity at the macula, 70% of these patients could be directly on either 3 monthly or 4 monthly interval injections at the end of 2 years, that is 100 weeks. That is what I really need from my anti-VEGF that I use for my patients. I need it to have a good drying capability. I see this as, the improvement in the visual acuity is a byproduct of drying of the macula. It has been repeatedly proven in different studies that brolucizumab in comparison with aflibercept has significantly higher capability to dry macula. This is again a snapshot from Kingfisher trial. Not only at the end of the study, but starting from the first injection to the last follow-up, you had better responses and cumulative responses. So the more number of patients who could have dry macula kept adding till the end of the study. This particular slide, again from Crystal and Kite, shows us that all these clinical and subclinical achievements could be done with fewer number of injections. So if you look at this particular slide, at the end of 100 weeks in Kite and Crystal, the number of injections used, brolucizumab used in comparison with aflibercept were 11:15 in favor of brolucizumab and 10:15 in favor of brolucizumab. So obviously good response with lesser number of injections. There's a lot of talk about safety of brolucizumab since this molecule has been put in place and it's on our shelves. So if you look here, I would like to concentrate on Kite trial. The Kite trial had the cohort which resembles genetically the kind of patients we treat, that is Asians. In Kite trial, both the arms basically had comparable IOIs or intraocular inflammations. If you look into the Crystal trial, there were 3 such patients who had vascular occlusions, but all the 3 were actually attributed to the disease process, but not to the drug interactions. Similar profiles were also seen in Kingfisher trial. Last but not the least, brolucizumab is a molecule which is undergoing a phase 2 trial to treat one of the 2 most resistant cancers known to the humankind, Kaposis sarcoma and blastomas, the cranial blastomas. So obviously when we have a drug that has been tried for one of the most resistant diseases in the human body, I would like to believe that 6 milligram vial which is handed over to me for my patients, it packs a punch. So thank you.
Thank you very much for this excellent presentation, Mandeep, and also on time. Thanks a lot. So we'll wait and see Dr. Prasan, then we will discuss. You can join us here, Dr. Mandeep. So can you please run second?
Can I have my slides, please? So at the outset, let me thank Dr. Amri, the MION Scientific Committee for giving me this opportunity. I'm going to speak on this debate and why choose faricimab over brolucizumab. So the first slide is about brolucizumab, and this presentation of mine is quite unique because I have very few slides on faricimab. Most of the slides will be towards brolucizumab, and you'll realize that why I'm doing this. So as you know, brolucizumab works primarily on only one molecule, which is the VEGF. Please note that it's only one molecule. And there are various studies which have shown that 75% of these patients can be extended to Q12 interval, as Mandeep mentioned. 80% of these patients can also be on Q12 over a period of 48 weeks. So 78, 75, and 80% of these patients are on Q12. What about ferricimab? Now, ferricimab is a very unique bispecific antibody which attacks two molecules, the Ang2 and the VEGF. So in addition to VEGF, which is blocked by brolucizumab, you also have an additional action on acting on Ang2. And why Ang2 is important? Because Ang2 stabilizes, anti-Ang2 stabilizes the vessels, it reduces the leakage and reduces inflammation. So it's got dual inhibition. So over 2 years, again, it demonstrated durable efficacy, and you can look at the figures. 78% were at Q12, that means injections every 12 weeks, and 60% were almost at Q16. Similar results were also seen in neovascular AMD, whereas 80% of these were on Q12 and 60% on Q16, and the vision gains were comparable to aflibercept. Now we know everything about brolucizumab. Then the most important thing I wanted to drive the point is brolucizumab is associated with an intraocular inflammation, retinal vasculitis, and retinal occlusion. So if you open up PubMed, you'll see 40 presentations or papers relating to this. And the first article, which had come from American Society of Retinal Surgeons, which looked at the safety in September 2020, they clearly demonstrated that there are a lot of patients who can develop this. There are also papers of brolucizumab associated with intraocular inflammation without vasculitis. And this paper, which was published, which looked at the clinical pathological correlation, clearly showed that patients who develop this intraocular inflammation it's primarily due to type 3 hypersensitivity reaction. Then this paper from Caroline Baumel, who looked at what are the risk factors and how do you manage these patients, they clearly indicated that retinal vasculitis and intraocular inflammation after brolucizumab is characterized by variable occlusion of the vessels, including the retina and choroid. If you look at the PubMed search for faricimab with intraocular inflammation, there is not a single paper which looks at faricimab causing intraocular inflammation. These are the various images. Intraocular inflammation was reported in this patient with occlusion of the inferotemporal vessel. The lower left patient had symptomatic ocular retinal vasculitis just 34 days after the injection. And last, the one on the right showed occlusion of the retina and the choroid. Again, I would like to reiterate, no reports of intraocular inflammation with faricimab. The safety review committee also looked at how many percentage of these patients had problems. So 4% had intraocular inflammation, 3% intraocular inflammation with retinal vasculitis, 2% of these patients had occlusion as well, and 1% of this lost vision more than 15 letters. The overall safety of brolucizumab was also looked at in Castle and Cricht. I'm just highlighted those lower things. And if you look very carefully, you're again looking at figures like 4%, 2%, which are almost similar to Hawk and Harrier, though a little less. But this is a similar thing, a similar finding which you see both in Hawk and Harrier as well as the Kite and Castle trial. What is the real-world data? This is the real-world data from the website, where clearly post-marketing data has shown that we do have patients from UAE who also got inflammation in the eye. So now we know that brolucizumab causes the problem. So there are various scientists who looked at what are the risk factors and management. So risk factors were looked at, and we found out that female patients and Japanese origin patients and patients who had previous history of intraocular inflammation were all risk factors. Then there was an expert opinion of how to treat when you have these patients. So this is a famous chart where you will see big chart, intraocular inflammation, how do you treat, retinal vasculitis, how do you treat, retinal vein occlusion, how do you treat. So now you're talking in terms of giving an injection and starting to treat complications of these patients. These are two papers which looked at how patients had loss in vision. So this is a gentleman who had a 20/40 vision and had a counting finger vision at the end of it. This is another patient who had bilateral loss of vision from almost to no PL in both the eyes. So when you decide to treat brolucizumab, you're going to ask your patients to be counseled, and when you counsel these patients, this is the way you counsel. You give them proper advice about what are the risk factors. Every time they come, they want to dilate them. And this is a WhatsApp message from one of my patients, clearly asking, "Doctor, do you think brolucizumab really causes blindness?" And she sent me some YouTube videos as well. So this is a realistic world. So caution about using brolucizumab in one-eyed patients, no bilateral injections, female patients, Japanese patients. You need to do early diagnosis for these complications, prompt treatment, aggressive treatment, frequent monitoring. And these is important because the problem is if you don't diagnose them on time, they tend to lose vision. And the other problem is frequent monitoring you don't want, because that's the main aim. You want to use a medication for a longer period of time here. Lastly, the major side effects which no one mentions, insomnia in doctors. So my experience here is, this is a patient of mine who had problems and he was treated with faricimab, excellent response. This is another patient, DME, multiple injections, a vision of 0.05 improved to 0.4 without any complications. Lastly, this is a $1 million question every time you inject. So if an anti-VEGF has to be chosen, will you choose brolucizumab or faricimab in your relative? And the answer is very clear. It's going to be faricimab. And if you look at the left, tips to prevent insomnia, at the bottom you will find use faricimab. Thank you very much for your kind attention.
Thank you very much, Dr. Prasan. Okay. The question, Dr. Prasan, in one word, why you are prepared for faricimab? Only one word.
As Ahmed Khashab said, insomnia.
Dr. Rao, keeping aside the complications of brolucizumab, so comparing without, taking into account, what do you think about the two molecules?
So I had multiple patients who were on aflibercept whom I switched to brolucizumab with the hope that I can extend. And two of those patients have been very dear to me because they are under treatment for almost 2 years. And both these patients, after the first injection, came to me within a week. I don't know whether it's coincidental or not, or whether they are counseled so much that they are very apprehensive. They came up with redness, pain, photophobia. Treated with drops, they are fine. Now I started with faricimab for them and they are doing well. So there's no head-to-head comparison in my case, but I think to me faricimab seems to be a better option.
Yeah, I think very good presentation, both of you. I would like to put a few words to your presentation. The first is that both the molecules are wonderful. You can hear? Yes. Okay. Others can hear. So both the molecules are good, and we should also know how they work, because the faricimab, as it works, is a bispecific, so it works differently, and the other one blocks both the receptors of all the three isoforms. So I would say both molecules are good, but when you want to think about certain patients which have an increased sensitivity to get an inflammation, then I would rather choose faricimab. But I would also give a word of caution, my personal experience, that if I see a very aged patient, however, in any patients that go for intravitreal injection with both these molecules, I make it a point that I take an ultra-wide field picture to study the blood vessels. I'm not talking about DME, because DME, I feel they have a less chance of getting anti-hypersensitivity reaction because the vessels are already, endothelial damages are there. But in case of neovascular AMD, in very aged patients, I would very cautiously and repeatedly think before I inject brolucizumab. Okay? But both the molecules are good. I think with time we learn whom to inject, whom not to inject. But in mid-age patients who get other diseases like your fibrosvascular PEDs or any such thing, I think they respond pretty good.
I think both presentations are excellent. You stated it well, Prasan, for brolucizumab, and Mandeep, you excellently explained the potency of the drug. Actually, I use both drugs, and to me, Beovu or brolucizumab is an excellent drug. It is very potent, but only because of the safety alarm and safety issues, I will keep it as second or third line for very limited patients, because I have patients who are not responding to any drug, and they responded tremendously well with Beovu. But faricimab is now having the potency and the durability, so definitely, if I'll switch definitely to faricimab first. This is my personal opinion.
Okay, any comment from Mandeep?
I just would like to know whether how many of us are actually giving this extra caution to the patients when we inject brolucizumab, and whether it should be done, because I understand all these data and the IOIs or whatever our fear is. It's actually for us. So once you transmit it to the patients, they would obviously be come back for anything. I mean, even if they have a subconj hemorrhage or a little bit of irritation, they would think it's IOI and they'll keep coming back to us. So are we actually making our patients more apprehensive, and should we actually caution them or just be ourselves cautioned?
I agree. I definitely.
Yeah.
I will definitely would like to tell the patient exactly what we are fearing from the drug, and we need to explain this very well, because we do not want the patient to have an issue and do not report it. So over-reporting would not be an issue, but under-reporting it and having a problem that cannot be treated properly at the proper time is a big issue.
Yeah, giving the correct information is important. So when we take our consent, I always say to my patient, there is 3 to 5% chance that you might get intraocular inflammation. Around 80% can be treated well, but less than 1% can lose vision. But they do know they need the treatments, because 95% can be good. So many of them take the risk to get it treated. However, as I say, very aged neovascular AMD, I'm not worried about DME. Very aged neovascular AMD, I don't even offer.
Okay, thank you for all. But before we have to move from to the next, there is only 2 things I want to mention. Both of the medication are very good. And I think the last study regarding the diabetic macular edema, it doesn't show that much of a side effect of brolucizumab, and it found only in AMD. So I don't think that we have to be very cautious as before in related what actually, at least according to the study. And when we are using these medications, maybe we have to take a little bit of cautions, but not like before when we are dealing with AMD. Thank you for all our speakers, and we have to move to the next debate, and it will be between Dr. Patricio Lorenzo and Dr. Hassan Adibi, and they are going to talk about, are we using topical antibiotic steroid after intravitreal injection? Dr. Patricio, he say no, and Dr. Hassan, he will say yes, and let us see who will convince us. Thank you, Dr. Patricio. You have to go. No, Patricio, you are the last and first. Okay. You are afraid, Patricio, maybe, huh? Yeah, why you are giving Doctor the chance of Dr. Hassan first? Don't hide.
Can you hear me? Yes, yes. Okay, good evening, everyone. Thank you, dear panel. I want to thank, you have my talk. Yeah, on the lower left of your desktop screen. So thank you to Miom, thank you to the panel members, and especially to my friend, Dr. Amri.
What killed the thalamus? He was walking like that until I ended myself. I just feel so. Who is this IT? They should change the company.
Can we ask this question for the audience, please? A show of hand, who uses antibiotic before or after intravitreal injections? Okay. So who does not use any antibiotic before or after? I'll show my hand as well. Okay. So I think 50-50%. Yeah, you can see the. So let's see, Dr. Patricio.
Let's see if we can see.
Yeah, hopefully.
Are we ready? Yeah. Okay, so the topic is topical antibiotics and steroids in intravitreal injections? My side is no. This is not a fight, it's just a discussion, okay? So the controversy is why some of you are still using antibiotics. It is usually related to personal preference. You know, I'm not going to change now. Peer pressure. When I first came to the Middle East, I landed in Riyadh, in King Faisal, and my two Retina colleagues were using topical antibiotics after injection. So I said, why? I'm coming from Spain. We've not been using antibiotics for a good while now. Well, you know, you have to give something, and then if something happens, so in the end, I think that the main reason is for medical legal reasons, because they think that if the patient gets an endophthalmitis and you didn't give any sort of antibiotics to this patient, you're going to be condemned to guillotine or something like that, okay? So that's not the case, or at least from my side, it's not the case. So is it justified to give antibiotics? From my side, it is not. I tried to change it in Riyadh, I couldn't. I don't use them, neither previously nor after the injection. And it is being shown that there is no difference practically in using or not using antibiotics on the rate of presentation in endophthalmitis post-op. And actually it could lead to resistant development of bacteria that in the end can cause endophthalmitis, especially for people with repeated injections. As I said, the risk of endophthalmitis could be increased. How can we increase the risk of endophthalmitis by giving antibiotics? Well, your patient comes to the clinic, you give the patient one injection, and then you give the patient antibiotic or antibiotic and steroids, the typical Tobradex we use for cataract surgery for years. And the patient comes in a month's time and you again give the patient your whatever you use. So what you are using with your antibiotic, if the povidone iodine didn't kill everything, that maybe it doesn't, you're benefiting in one of the strains that are resistant to this antibiotic. You're actually killing the rest of the bacteria there and just allowing the resistant one to grow and to be there for the next and the next and the following injection you're going to be giving to this patient. And you're happy giving this antibiotic that is not going to kill anything because the only bacteria left is the one that is resistant to your antibiotic. So, okay, but you know, I'm defenseless. I cannot fight with this. I need some backup for my opinion. How can I tell my patients that they do not need antibiotics? Well, we have the societies. So the American Academy of Ophthalmology, for the perioperative things, it recommends a lot of things, but actually it doesn't recommend routinely antibiotics. And they also said that some studies increase the resistance by using antibiotics, resistance of the bacteria. For the Retina, perioperative antibiotics are not considered a standard of care, neither pre nor post, and it doesn't change anything regarding the rate of endophthalmitis. So yeah, you know, we are in the Middle East. We are different people. We are not Europeans, and we are not Americans. So we cannot compare with them. We are very far away from the States and from Europe, especially from Spain, which is nearly 8 hours flight. So what do we say? Fortunately, this year we produced the guidelines for the diabetic macular edema, the Mirate Society of Ophthalmology, and all the people in the panel it's just at the bottom of the slide. So what? Okay, that's what we said. Antibiotics are not recommended either pre or post injections. Patients should be given information about post-op complications and a telephone number to contact in case of symptoms, including increased redness, eye pain, vision reduction, or any symptoms of endophthalmitis. So now don't come and tell me we are not backed up. We are all backed up. Okay, what about the topical steroids? Well, in general, there is no indication for routine use of topical steroids. I can take it for some specific cases, and I think we will leave it for the discussion. And as conclusions, again, there is no routine indication neither for antibiotics nor for steroid use in intravitreal injections. And thank you so much.
Thank you, Dr. Raiz. Can you come, please? Dr. Hassan Dibi, now for talking for yes.
Can you put my presentation, please? Good evening. First of all, it's a great pleasure to be with you here. Thank you, Dr. Muhammad, for invitations to get in my homes 2022. It was great to have debate sessions and to look for the people how they are thinking, what is the current practice. Practice based on the evidence usually is the great one, but taking time to change our behavior. Dr. Patricio showed a lot of positive things regarding not using antibiotic, but most of the talk which I saw, it was not specific. Mostly talking about intravitreal injections. As you know, we have a lot of types of intravitreal injections. We are not talking about anti-VEGF, where most of the evidence showed really the rate of endophthalmitis is very low. Could I have my presentation, please? It is already. Do you want it? So when we are talking about intravitreal injections, we are omitting here the steroid. Steroid is not the same as anti-VEGF. How many of you that when are doing 25 gauge vitrectomy, not using antibiotic? I'm sure no one of us, even 23. So suppose that you are putting 20 gauge needle in intravitreal and you're having an access and you have very thin sclera. Do you think that it will not leak? You will not have an access to the vitreous, which love to have endophthalmitis. This is why the people, they are more meticulous and looking to put this antibiotic. Very most. We have disinfections. We have antisepsis. We are using bavudine. I'm looking for my, because I have a lot of evidence could go with what you said, which I'm not disagree with that, but I have to more specific in what I am saying. So let's us to say, this is just simple. The reported endophthalmitis rate is expected to be 0.02 to 0.085. So we have variations, and we have higher than what would be expected from simple, fast, and relatively traumatic procedure. The two key issues involved here is the pre-intravitreal injection disinfection using bavudine and the use of topical antibiotic prophylaxis. This is the most of the people and have a lot of controversy. So we have a lot of studies coming from ophthalmology, from Journal of American Ophthalmology, and currently bavudine with the strict antisepsis rules is the only prophylaxis that was proven to have an effect against endophthalmitis after intraocular surgery. We are talking about intraocular surgery. One of the most controversial area of peri-operative care of intravitreal injection is the use of topical antibiotic before and after the injections. So would you use of topical antibiotic as prophylactic post-intravitreal injection of steroid? Yes or no? This is to you. Any one of us? I don't think so. He's completely confident to give intravitreal steroid injections without antibiotic. So there is an adequate evidence to support the routine use of prophylactic pre, peri, and post-injection antibiotic to reduce the risk of the endophthalmitis. But we still give prophylactic, even though with all this evidence that you think antibiotic after intravitreal injection of steroid for many reasons. Why? There is many confounding factors, large variations in the intravitreal practice patterns, because I'm doing in that way, you are doing in that way. The setting of the injections, is it simple, contaminated, or not? The concentration and duration of povidone application, and the various types and duration of topical antibiotic. Lead speculum, is it sterile or not sterile? Surgical mask, gloves, post-injection iPads. All this is factors getting in the involvement when we are injections and in the practice. And we don't have control, we don't have clinical trials to show which one is the higher risk of. So it is difficult to ascertain whether the use of topical antibiotic reduce the risk of endothelitis after injection. So it is one of the factors, not all the factors. Number two, the rate of endophthalmitis post intravitreal injection of steroid is higher than post anti-VEGF. Why? We have to think. It is not coming. We have a lot. So let us look for the clinical practice. We have one of studies just only recently by Simelson reported that, and the conclusion showed that endophthalmitis following intravitreal steroid injections may occur more frequently than other intravitreal injections. And dexamethasone attributed endophthalmitis remain uncommon, and prompt intravitreal antibiotic treatment seems to be effective in this series. Just focusing in the intravitreal injection. Another study, which is actually having multicentral study done in French, and show that the incidence of presumed endophthalmitis after intravitreal injection of antivascular endothelial growth factors or corticosteroids was low and progressive. So we know it, but we don't like it if it's happened, and we try to prevent it as much as possible. So prevention and management remain challenging, and no one know what is the best practice to prevent. And it remains to be determined whether the findings of this study are relevant for other countries using different technical for intravitreal injections. Association of acute endophthalmitis, the risk of acute endophthalmitis after intravitreal injection appear be higher for corticosteroid compared with anti-VEGF. And more specifically, the dexamethasone implant, which we are using a lot nowadays in comparing to intravitreal triamcinolone, were associated with more than 3 times more endophthalmitis cases than anti-VEGF agents. Another study showed that the incidence of the rate in the topical antibiotic prophylaxis after intravitreal injection was similar to groups, and changing the current clinical practice, no antibiotic prophylaxis had no effect on the incidence. So the one that's saying that there is increasing the resistance is not there. Even though with the antibiotic, it's almost the same rate. So resistant and normal flora getting and more aggressive endophthalmitis is almost no evidence practically in that way. Then the association, this is result of total of 387,000 comparing to 18,000 steroid intravitreal injection were performed. Endophthalmitis was 6 or 7, almost 7, with 95 confident interval, with p-value significant times higher. So 7 times higher post-steroid injection compared with anti-VEGF. So we have to look for the cause. So in summary, despite the availability of published guidelines, considerable variation still exists in real-life clinical situations, and large-scale, multi-center randomized controlled trials with standardized pre- and post-injections methodology to evaluate the role of peri- and post-injection antibiotic in the prevention of post-intravitreal steroid injections endophthalmitis seem warranted. In the same time, remember that there is, in Asia-Pacific, more than 84% of the physicians were still using antibiotic. When you compare it with the people in the United States, only 11% using. In Japan, it's still mandatory to use antibiotic in peri and post. So still, we don't have the clear, gray zone either to give. Until we get really high level of evidence, then we can say, no, we can use antibiotic in steroid intravitreal injection. In a patient with steroid implants, there is a large, entrance, and there is possibility of a lot of leaks and getting in the pathogen inside the eye. Thank you very much. and thank you for giving me the chance.
Excellent presentation, Dr. Patricio. Thanks a lot for clarifying these points. Actually, you remind me of something. I had a patient coming to me from Japan, and she was for injection. And I prepared her. I told her, okay, we are going for the injection. She told me, you are not giving me an antibiotic? I told her, no, I'm not. She told me, but they used to give me antibiotic in Japan. But we are not using here, and all the guidelines does not state that we need to do this. She refused. She left. She didn't use it. So this is reminding that different areas throughout the world is acting differently.
I recall one of my stories that I have young girl with the anterior uveitis complicated with the macular edema and being injected with anti-VEGF for a long time with systemic, immunosuppressive medications, and her macular edema not responding very well. So I get her to OR and I give her, dexamethasone implant, Ozurdex. First one, second one were great, no problems. Third one, I gave it to her. You know that pediatric ages, they have very thin sclera. The mother called me in the same night, or second day, I think so, and she said, my daughter, her vision is not good, but her eye is quiet, you see. I said, please come to the emergency room. And I found that she's having very bad vitreous infiltrate. So sometimes, might be we are treating ourselves, not treating our patients, but important to secure that you did all the best for your patient. We have flora, we have blepharitis, we have regurgitations from the nasolacrimal duct obstructions, and saying a fact, there is a resistance, it's not we are using that for 5-7 days. It's not that for long run of the patient. And putting in your mind, steroid is immunosuppressive medications, decreasing the immunity of the eye. So it's an easy for flora to get in and getting infectious. So this is why we are using. Give me evidence, I will say, okay. But till now, we don't have that solid evidence.
Dr. Hassan, my understanding that you agree partially with Dr. Patricio that if the injection is anti-VEGF, you won't give any antibiotics, right? Am I right?
Yeah.
But if steroid, you would definitely give.
Yeah, of course.
So, Patricio, if you are giving steroid, so we agree partially. We agree partially on the anti-VEGF. Steroids and antibiotics are not mandatory. But now Dr. Hassan is saying because of the large port with Ozurdex, he would definitely give antibiotics.
Yeah, fine, but listen, Awadara, you're a VR, and we are all VRs, okay? And it's a joke, it's a real joke to think that if you're going to introduce, I don't know, 2-3 pseudomonas in the middle of the vitreous cavity, or a Staph aureus or a strep, you're going to kill that bug with a drop 3 times a day. That's ridiculous. If the steroids gives more endophthalmitis, despite using antibiotics, it's not because you're not giving antibiotics. It's because it's a larger incision, and you can introduce in the middle of the vitreous cavity a larger amount of germs that you're not going to kill with your 3 drops a day. Forget it. It can give you peace of mind. God bless you. But you're not going to treat that infection.
Could you explain for me why we are still in our practice in small, incision cataract, in varsa-planar vitrectomy 25, 27 gauge, still using, antibiotic? Still we have, the small microbes will not get in the eye and will not be killed. So still this is the practice until we have solid evidence, either, meta-analysis or clinical trials controlled, then we can say. If you go to the court, you will not be based in retrospective studies. Because other colleague will come, why you didn't use it? What is the harm? There is no really solid evidence say that there is a harm for the patient. This is just presumptions.
Yeah, I absolutely agree in certain points. Yeah, it's true. But the very basic point of sterilizing the area before you inject and the contact period of that betadine drops, which goes to the conjunctival sac to stay there for at least 2 to 3 minutes before you inject, I think that is the paramount importance. Then comes the last issue, which is very small, whether to use antibiotic post-injection. I'm not talking about pre no one uses, post-injection or not. Yeah, definitely those points has to be in place. That is why at the end of your injection, you put a drop of betadine and then you ask we patch it for 5 minutes, then we don't. But we do use lubrication to wash out the eye. Antibiotics post intravitreal injection or anti-VEGF, because you use a 30 gauge needle, probably it becomes only for me it's a medical legal only. It's not, there is no, I don't have evidence. However, if you look into the Ozurdex or Iluvien when you give, the gauge of the needle is thick. So it's almost like doing a micro-incision vitreoretinal surgery with one port. So then the question comes, should I use an antibiotics in that post-injection as I do my vitreous surgery? Yeah. So that is a point to ponder, to think. I think it's absolutely on a personal basis what you think is best for your patients until and unless you get any catastrophe. Okay? So yeah, for me it's medical legal, absolutely. But yeah, in intravitreal with 30 gauge, I don't bother.
I think with that, I think we can leave with that both points are valid. Although for UAE, that's why we put the guidelines, that it is not necessary. So whenever any, for example, God forbid, have any our colleagues or ourselves have endophthalmitis and not prescribed antibiotics, this is not necessary for our injections anymore. Not for anti-VEGF, not for steroid implant. Whomever wants to use it, they can still use it. Whomever does not want to use it, they do not have a base. They have a base enough to support them. Okay? Yes.
Okay. 50,
Yeah.
yes.
I think it is.
So the debate still goes on, yes.
So I think we need to go to the next debate.
We'll call upon Dr. Fahd Kohel will discuss PDT in CSCR versus Dr. Amin Marashi will discuss the micro pulse laser in CSCR. So Dr. Fahd, please.
Thank you. Thank you for the kind introduction. Can I have my presentation, please?
Presentation, Dr. Fahd.
Not this one. No, not this
not
one.
This one.
PDT.
This one, Doctor.
Yes, this one.
Yes, last one, please.
Okay, so my name is Fahd Kohel, previously based in the UK, but 6 months ago I've moved to Dubai, so I'm one of the UAE doctors, alhamdulillah. So very quickly, we all know what CSR is. It's a chororetinal disease. You've got accumulation of subretinal fluid causing detachment of the neurosensory retina. When the macula is affected, it causes decreased vision, diminished contrast sensitivity, distorted vision. And we believe because there's a dysfunction of the choroid as the primary cause, so you're getting thickening of the choroid, and that in turn leads to a breakdown in the blood-retinal barrier, leading to a neurosensory detachment. And the disease tends to occur in men, although it can affect women, but mainly men. And the most important risk factor is use of oral steroid. So whenever you have a patient with central serous retinopathy, ask about steroid, any steroid cream, steroid injections in the back, in the joint, steroid inhaler, nasal steroid spray, to try and find out a trigger for their CSR. How does PDT work? Well, it basically remodels the choroid, and I believe it's the only treatment that actually has a tangible difference on the disease. And it leads to then cessation of the subretinal fluid by reducing the choroidal congestion, the hyperpermeability, and the leakage of the choroid. PDT is highly effective, with remission in 90% of patients, with around 20% of patients, in my clinical opinion, where the fluid can recur or the CSR can recur. This is a case in Sheffield where you've got your typical CSR, you've got the mottling nasally of the RPE with a neurosensory detachment. There's no hemorrhage, there's no drusen. It was persistent, more than 3 months. The patient was disturbed, so they wanted PDT, so we did a fluorescein angiography, identified the area of fluorescein hyperfluorescence. This is the OCT showing the chronic subretinal fluid with intraretinal edema. Obviously, we then set the PDT, the spotlight of the PDT to correspond to the size of the area of hyperfluorescence. And this is the patient after PDT with full resolution and no recurrence of their subretinal fluid. But there's a problem. PDT is great, but since May 2020, there has been a worldwide shortage. And that's because the new company, Kefla Pharm, which makes it for the rest of the world. So Bausch & Lomb acquired the rights from Novartis, but they only make it for the US. And then this German company acquired the rights for the rest of the world. And for whatever reason, there was a difficulty in the manufacture of Visidyne, and they don't expect to be online till the end of 2023, which is a real worry. Or do we need to worry? Because this is a graph from the VG trial, which compared a pregnenolone, which is a mineralocorticoid antagonist, versus placebo. And as you can see in the placebo arm, which is the blue arm, between baseline and 12 months, there's no loss of vision. I'm sure the patients are very upset with the effect the CSR is having on their vision, but there's no loss of vision. And we know that from our clinical practice. So with the lack of availability of PDT, should we offer an alternative treatment to patients? Patients are distressed. They come to your service really perturbed by this vision disturbance. It is tempting to try and offer them an alternative therapy. But with any intervention, there's a risk and benefit. And also, we're not cowboys, we're doctors. We should always offer a treatment if there's a proof of efficacy and we are confident about their safety. And ideally, we should have a randomized controlled trial. So I have one. This is a randomized controlled trial looking at the long-term follow-up of chronic central serous retinopathy after successful treatment with PDT or with micropulse laser. So the original study was for 8 months, and it was a comparison between PDT and pulse laser, micropulse laser. And at 8 months, if you were successful and the subretinal fluid was resolved, you were then included in this study, where they looked at the patients for a further 12 months. So they had 20-month follow-up. I'll be quick. So the bottom line is, you got better choroidal thickness reduction with PDT. With micropulse, you can see that even though you get resolution of the subretinal fluid, the edema recurs at 20 months. Whilst with PDT, you didn't see that. One very quick thing. At the final visit at 20 months, 93% of the patients with half-fluence PDT still had resolution at 20 months, as opposed to only 53% of the patients in the micropulse. Also, look, they were managed to include 37 patients with PDT with resolved edema, only 17 micropulse patients. It doesn't work. So very quickly, I won't take too much time. So my current practice, due to the lack of long-term data with micropulse, unlike PDT, with the low risk of vision loss due to persistent CSR, because of the superiority of PDT over micropulse, because of the high recurrence of CSR with micropulse, I am currently observing my patients. I see them regularly. If they develop CMV, I of course offer them intravitreal anti-VEGF. I stop PDT, and I'm waiting for the day PDT comes back. But I'm not going to offer an inferior treatment to this group of patients.
Thank you, Dr.
Thank you.
Fahad. Thank you, Dr. Fahad. Come, you can come, Dr. Hifati. Is Dr. Amin presentation ready?
Hello, everybody. I would like to thank Dr. Al-Amri for inviting me to this session. Let's start. I have no financial interest in the products mentioned in this presentation. Dr. Fahad has already presented the problem with CSCR. It is a self-resolving disease, but it may cause visual bothersome metamorphopsia and reduction of vision. Some cases may lead to macular damage due to visual threatening complications such as macular neovascularization. PDT is proved to be safe, an effective way to treat CSCR. But we have big issues. Vitroprophin is unavailable. We have a shortage, which is causing cases on PDT waiting list to accumulate, threatening the visual prognosis of young patients. Those patients usually are at the working at productive age. PDT is expensive. It's a very expensive procedure. It needs an invasive imaging techniques such as fundus fluorescein angiography or ICG, which are also not very safe. It needs a protection of sunlight post-treatment. PDT requires a skill and learning curve, especially of young ophthalmologists like myself. Do we have other evidence-based treatment exist besides PDT? Well, those in favor of microsecond subthreshold laser, which is termed as micropulse laser. We have a success rate ranges from 67% to 100%. Recurrences up to 23%. Side effects is none. This is very important. That means we can repeat it. Even Dr. Fahad has mentioned we have recurrency up to 53%. So be it, no problem. We repeat the treatment. We do that with diabetics. We do that with AMD. Why we don't do it with the CSCR? So, vitroprophin is not needed. This is an extremely important point. Safe and effective. Subthreshold microsecond laser is cheap. It is cheap to perform. Subthreshold microsecond laser requires short-term learning curve, especially for us retinal specialists. We're already utilizing argon laser all the time, so the learning curve is very easy. No need for invasive imaging. As a guide, like fundus fluorescein angiography or ICG, fundus autofluorescence or OCT, I use infus OCT, structural infus OCT, to utilize it. It's more than enough. Subthreshold microsecond laser can be repeated safely. This is very important. I shortly will show you how I apply my settings. I put 600 milliwatts with the duty cycle 5%. With duration interval only 0.2 seconds. I go to non-edematous area at the nasal side of the retina, and I do a couple of laser applications to see only a reaction of the RPE, not a burn. Let's say I had a 600 milliwatt with this settings 5%. I only use 300 milliwatt, 50% off. So I go to the edematous area or the area of subretinal fluids, and I start to do the laser to all the area, and I will be generous at the area of the leakage. Let's take a case. This is a female, an optometrist, and she's a sister of my best friend. So after confirming the diagnosis, because we're worried about a tumor, I don't know why. It's not going, oh, okay. Here, her fundus fluorescein angiography. It's a video. Can you start it, please, for me? Can you start the video for me, please? He's not hearing me. It's a video. Can you start, please? Huh? So it's just a video of dynamic fundus fluorescein angiography showing smokestack leakage, nothing fancy here. It's okay, you can leave it. Okay. Okay, it's not important, it's not important. You can go to the OCT, please. For the OCT, we can see subretinal fluids, we can see pigment epithelial detachment, and we see the thickened choroid with dilated halars. Dr. Fahd has mentioned that after the treatment with subthreshold microsecond laser, the choroid is still thick, but we are treating a patient, we are not treating an OCT, so I don't care about the thickness of the choroid. I care about the patient is recovering vision. She had 20/20 vision. There is no any disruption of the RPE for this patient. Thank you very much for your attention.
Dr. Nazim, would you like to give any comment about your preference at this subject?
If you look at your debate, if I look into the boxes what you tick, then probably Amin has ticked more than Fahad. But if you look into the science, I think even a place and replace trial, which tried to, it's the same study what you quoted, but this was published in American Journal of Ophthalmology, and that has clearly shown that you treat both the patients with micropulse, your high density micropulse laser, and other side PDT, half dose verteprofen. And most of the patients which did not respond to micropulse responded to PDT, but it's only 15% of patients of PDT which did not respond. It is possible. Had a micropulse, but they didn't respond. So the PDT scored over the micropulse. But the micropulse patients which are treated, they resolve by end of 7 to 8 months. They ultimately resolve. But what is the side effect? The visual outcome was not as good as it was resolved earlier. However, these were the patients with chronic CSC, okay? We are not bothered about acute CSC. Acute CSC with micropulse may work as well as good with a very low threshold focal laser thermal. But these are all what we are concerned with PDT is for chronic CSC. Yes, the best thing the PDT works because it causes a choroidal remodeling, and that's the reason we need an ICGA. And that's the thing, when you debate it, probably you tick more. Okay, I think both has a place, but if you look into the science, I think half dose verteprofen works good for chronic CSA. But your micropulse is still good because 50% can improve, but it takes longer time.
I totally agree with Dr. Nazim. PDT is excellent, and the problem is the patient with the micropulse is impatient. Is just move around, and get other modes of treatment, and by the end could be the credit of the micropulse goes to another mode of treatment, because as Nazim said, it is always delayed. And for me, unfortunately, it didn't work because of the movement of the patients. They want result right away. So yeah, I totally agree with what Nazim said. The only drawback, it's easy, it's simple, you can repeatable. However, the delay in the outcome is a drawback, definitely.
One of the reasons why I just have never bothered using micropulse in my practice is when I was in the UK, PDT not being available, in cases of extrafoveal CSR, I would give standard macular laser, which is much more powerful than a micropulse. Yes, it would work, but within 3 months, the CSR has come back. And the patient just says, they're still as distressed, still as annoyed, and Then I do the fluorescein again, find that the leakage is now reverted more foveally, and I don't know whether actually by just letting it get better by itself, whether I've done something in the best interest of that patient, or waiting for the PDT to actually make a big difference to the health of that eye long term. Because I'm modifying the disease.
Thanks a lot. I think both presenters are excellent, and both points are well taken. Dr. Amin, you did a great presentation. Dr. Ravad, I loved your presentation. But we need, for the sake of time, we need to rush. I think we have to go to the next presenters.
Dr. Magdi will discuss OCTA in wet AMD.
In neovascular AMD. First of all, let me thank Dr. Mohammed Al-Amri. He's going back and forth now for every presentation, and I know that he's boiling from inside, but calm down. Thanks again for the kind invitation. My presentation today, and I hope everybody is not sleeping, defending OCTA in neovascular AMD. Let's speak about fluorescein angiography. We all used fluorescein angiography for decades, and it was the only tool. It was the standard of care doing fluorescein angiography to know if this patient had a CNV or not, and it was able to classify the CNV type 1, type 2, type 3, and even in the era of photodynamic therapy, we used to say occult, classic, predominantly occult, predominantly classic, which we don't use these terms nowadays because CNV means injection. There is nothing else. So this was fluorescein angiography. It was quite good enough to say this is type 1 under the RPE, type 2 above the RPE, type 3 intraretinal, which is RAP, and then goes down to the choriocapillaris. And when the OCT came, we said there is nothing else we are dreaming of. We can see all the retinal layers, knowing that this is type 1 under the RPE, type 2 above the RPE, with all the fluids and cystoid spaces, and type 3 starting in the retina above the RPE. So we didn't dream of anything else. So comparing fluorescein angiography with OCTA, we need to know what is the difference between the two imaging modalities. And second thing, what information we can get from OCTA. Of course, we do OCTA with co-register structure OCT, and then we can decide which is better for us and which is less harmful. Let's go to the OCTA. These are the questions. If I answered, it means that OCTA will win. Can OCTA classify CNV into type 1, 2, 3, and 4? And can OCTA clarify the activity of CNV? And is it helpful in following up CNV after the intravitreal injection? And can OCTA sometimes be better or superior to fluorescein angiography in detecting CNV? Let's answer these questions. First one, can OCTA classify CNV? It's easy because it's a three-dimensional image. It can show you that under the retinal pigment epithelium, we have to look down there at the level of the outer retina because we have four slabs: superficial plexus, deep plexus, outer retina, and choriocapillaris. So if you look at the level of the outer retina, we will find that the membrane is there in a three-dimensional image. Type 2, look at this. We can see it clarifying in the what we call C-fan, and we can see 3D image of the CNV, and sometimes you get astonished. If you look at the fluorescein and compare it with OCT angiography, it's completely different. You see all the details of the membrane. How about type 3? Yes, but here the trick. We have to look at the level of the deep plexus because type 3 starts inside the retina. So if we look outside the retina or at the level of the outer retina or choriocapillaris, we will miss the membrane, or we have to adjust the slab. So it can classify. How about type 4? Type 4, we used to have ICG. We don't have ICG anymore in our country, and in most of the countries, the dye is not there, and it's very expensive. But look at the fluorescein angiography and look at the OCT. We can anticipate there is a polyp under this because this is hemorrhagic RP detachment, but OCTA, again, can show you two branching vascular network, one in the macula, one in the peripapillary area, if you do it properly. So again, it can classify all types of CNV crystal clear. How about the activity? Look at this picture. 3D image showing the C-fan with increased density of the vascular network, extensive arborization and anastomosis, and looping within the CNV. These are all criteria we all know when you look at the OCTA in CNV. So this is active CNV with all the criteria I said, and we can represent that by blooming tree with all the leaves and all the green things. And once it is inactive, we can find only the trunk without any leaves, without anything. That's why we call it dead tree. So blooming tree versus dead tree, it's easy to differentiate between active and inactive. And can we follow up with OCTA? Yes, but you have to use the same machine because there is no standardization between the machines. Dr. O might say, we cannot do OCTA in one place and then do it in the other place, and I agree with that. But look at this. First injection, second injection, third injection, only the trunk. So again, we should not inject in this, and with the co-register B-scan, we can see the flow in pink, and we can see there is no flow in the membrane. So again, we can follow up with OCTA with the co-register B-scan. We used to say fluorescein angiography is the standard of care, but we look at this patient. This patient has been injected many times. Is that a leakage? Is that a stain? We used to say, whatever the experience you have, is it a leakage? Is it a stain? Do we need to inject more? Before the era of OCT, fluorescein angiography was not quite good enough in answering this question. But in OCTA, look at this. With OCT, we would know that the retina is flat after the loading dose, and we don't need to inject anymore. But again, recurrence and relapse, and then you inject, and you say, is this a fluid? Is this a large outer retinal tubulation? OCTA can answer this. It's a dead tree, there is no need to inject anymore, and this is a dry macula. So again, this is very helpful if you cannot differentiate between the fluid and outer retinal tubulation. The last thing is OCTA can be superior to fluorescein angiography and regular OCT in detecting silent CNV. This is well-established case with a CNV in the right eye and flat irregular RP detachment in the left eye. And this is what we call silent CNV, which is discovered accidentally in the other eye of well-established CNV. There is flat irregular RP detachment, there is no fluid, there is no hemorrhage, there is no exudation, only OCTA can detect CNV. This is my last slide. So again, we have to know the difference between both of them. Fluorescein angiography is invasive, OCT is not. You can repeat it anytime. It's two-dimensional, OCT angiography is three-dimensional. Interpretation based on dynamic flow, and sometimes you lose the flow because of media opacity. No, it's static and you can repeat it anytime. Wide field and small field is not in our scope because it's a central lesion and contraindication. We have a many contraindication for fluorescein angiography. We have no contraindication. So why to vote for OCTA? Because it's non-invasive, it is reproducible, it is combined with structural OCT, equally effective or even better than fluorescein angiography. Thank you so much.
So we have to answer with Dr. Madhav. Yeah, these 4 questions. Excellent as usual.
Good evening. At the outset, I would like to thank the MOM committee for giving me an opportunity to speak. Well, it's difficult to speak after Professor Magdi Mosa. He has done a beautiful comparison of OCT and IVFA. Well, I'm going to speak on fluorescein. Why do we need a fluorescein in management of neovascular AMD? So it is first developed in 1961. Fluorescein angiography, as we all know, has been a standard of care in the diagnosis and the follow-up of myriad of retinal vascular disorders, especially the neovascular AMD. It's based on the intravenous injection of sodium fluorescein and non-iodinated contrast agent, followed by the acquisition of serial photographs to visualize the patency and permeability of the retinal vessels. Now, it's a dynamic information, as Dr. Magdi Musa said, regarding the transit of blood as well as the identification of dye leakage, which is fundamental to assess the vascular leakage and the integrity of the blood retinal barrier. Fluorescein can also investigate the RPE disruption, documenting the window defect. Historically, it is the go-to imaging tool to evaluate the peripheral retina. And we see a lot of changes in a peripheral retina, especially in the exudative AMD cases. Now, traditional angiogram visualize 30 to 50 degree of the central retina. Now, we have a wide field angiogram, which covers up to 50 to 105. And we have ultra wide field angiograms, which gives 105 degree images. We can visualize much more in exudative AMDs, the changes which are happening in the neovascular AMDs. Now, there could be some adverse effect in fluorescein angiogram, like mild, moderate, and severe. Severe is very rare. The visualization of retinal vessels provided by a fluorescein angiogram is limited to the retinal vasculature, and it can also have a masking effect underlying the tissue fluorescence. Now, it's not just the fluorescein, which it is the dye-based angiography, which is important, or the gold standard in the diagnosis of age-related macular degeneration. It has got high sensitivity rates in detecting neovascular fronts, and FA and ICGS still face a number of challenges, sometimes in a busy clinic. Now, it is still indicated in difficult cases in which use of OCTA alone could limit the clinician's ability, as shown by Dr. Magdi Musa, a silent, non-exudative macular neovascularization, where you don't know whether to treat or not to treat. Though you see a exudative AMD in the other eye, you don't know whether to treat them. We get the dynamic information and investigate the activity of macular neovascularization. So what changed? It's the ultra-wide field in intravenous fluorescein angiography, and OCTA is unable to detect the neovascular leakage and cannot image the entire retina, which is, I mean, in terms of commercial availability, we still don't have it. We most often look at the central retina with the OCTA. So angiographically, we can divide the neovascular AMDs into 5 types: classic choroidal neovascular membrane, occult membranes, microaneurysmal choroidal vasculopathy, polypoidal choroidal vasculopathies, and retinal angiomatous proliferans or proliferation. The most common type of neovascular AMDs are in some categories, especially in the Asians, and this population is PCV and microaneurysmal choroidal vasculopathy, followed by classic occult and RAP lesions. Whereas in Caucasians, it could be the other way around. We could see a classic occult RAP lesions. And why do we need to know about this? Because they present differently. The best corrected visual acuity at the time of presentation could be different. Now, different types of CNVMs are different in terms of demographic risk profile, clinical manifestations, visual prognosis, and response to the treatment. This is the important slide, which shows all the 5 varieties of subtypes of neovascular AMD. Starting from the classic, we generally speak about classic as leakage from the early phases with fuzzier margins in the later phases of the angiogram, which is classically cartwheel appearance in a classic membrane. The second one is the occult. We talk about the late choroidal fluorescein, which comes in the mid and the late phase of the fluorescein angiography. It's a late leakage. The third one is microaneurysmal choroidal vasculopathy, which will have a multiple focal hyperfluorescent spots on a fluorescein as well as ICGA in the first 6 minutes. And whereas the polypoidal choroidal vasculopathy will show a subchoroidal, subretinal orangish lesions, exudative maculopathy. On a fluorescein angiograph and ICGA, you will see multiple hot spots. And on a OCT, you will have a peaked PEB and a double layer sign. Whereas RAP lesions can have an intraretinal, subretinal, or a preretinal hemorrhage and a dipping of the vessel with a small exudation. And you can also see a retinal anastomosis on an angiogram. These are important factors which will tell us about the types of angiogram, types of neovascular AMD. Based on it, we can decide anti-VEGF. Otherwise, we will all be seeing OCT and define just a neovascular front and keep injecting. So it is more than, we would understand the basic pathology of in these kind of neovascular AMDs. Now, these are the pictures of classic membrane. You can see a typical membrane in a post-inflammatory eye. And here you see occult membrane, a late leakage. And the third case is about the PEDs, and you see on a fluorescein and on a OCT, the hot spots, which corresponds to the lobules. And it is also important in cases of anti-VEGF treatment to follow up to know the prognosis. So in all, The disadvantages of OCTA will be limited field of view, inability to view the leakage, increased potential for artifacts. It could affect by blinks, movements, vessel ghosting, and inability to detect the blood flow below the slowest detectable flow. These are the disadvantages why we can't use them in our clinical practice routinely to diagnose neovascular AMD. And what do we need in neovascular AMD then? It's a multimodal imaging technique. We need color pictures, autofluorescein, IVFA, ICGA, OCT, and OCTA, and not just the OCTAs. IVFA needs reading skills. As we all know that when I started in 2000, probably I was seeing a black and white fluorescein images. Then came the digital image. And you need really a skill to read the IVFA. Whereas OCTA, you just read about the medusa head, loop, and a dry tree appearance. There are many instances where we are undecided still after seeing the membrane on a OCTA. We don't know whether to treat them or not. So my goal is definitely I would stick to fluorescein angiogram and the OCT rather than OCTA and the clinical pictures. Thank you.
Thanks a lot. Thank you, Dr. Madav. Excellent presentation as usual. Can you come, please? So a quick question for the audience. Who still uses fluorescein on daily basis for choroidal neovascular membrane? Anyone not sleeping? One is only using? Yeah. Myopic CNV only. CNV, okay. So minority. I think because of the, now we have the great potential of the OCTA, some even rely on OCT only to diagnose choroidal neovascular membrane fluid. So I think with the OCTA, even with the point that Madhav just mentioned, that it is not a wide field, I think you just answered this, that we do not need that in this disease, in choroidal neovascular membrane. So what is your opinion, Dr. Mike?
I know his job was very difficult to defend something which is decaying now. I mean, decaying, we don't use much fluorescein angiography, but again, we are speaking not about OCT angiography because you are doing OCT angiography with the structure OCT. Once the machine starts to take the cube, it will take a structure OCT. And I think structure OCT taken with, or that we call co-register, taken with the OCT is much better than the regular OCT. Why? Because you have a flow. If you look at the flow with the pink color in swept source or different other colors in other machines, you would know if it's very high flow or not, and you can judge if the membrane is active or not. And once you find the flow without anything compared in the structure OCT, you would know this is a silent CNV. So I'm not speaking to be honest, I'm not speaking only about OCTA. You have to have OCTA with co-structure OCT in the same time, judging the activity and the follow-up of the membrane. And I don't use fluorescein angiography anymore because of the invasive. Sometimes the patient has reaction at the first 2 minutes. You will never get the rest of the sequences. And third thing, we used to use fluorescein angiography. Will never know this is a leakage, this is a staining. So again, it is very difficult to find out.
Thank you very much for the very interesting debate and discussion. I think we have to move. We need to have to move. Thank you. We'll call upon Dr. Noor Al-Mansouri for discussion of laser treatment of atrophic holes in lattice. Yes, lattice degeneration versus Dr. Danish Talwar for no laser for those atrophic holes in lattice degeneration.
Good evening, everybody. Thank you for all people who's attending until now. I know I'm already feeling sleepy already. So I would like to thank Dr. Mohammed Al-Umari for this invitation, and it's my pleasure to be among you and to meet you in person after a very long period of virtual meetings. So my debate today, I don't think it's something against, it's just a continuation of what's going on with the other, with Dr. Talwar. So I will talk about When to laser asymptomatic lattice. My name is Dr. Noor Al-Mansouri, consultant ophthalmologist, vitreoretinal surgeon, Samaya Specialized Center, Abu Dhabi. So, would you do laser for our asymptomatic lattice? I think no, but there are certain indications where do we have to do a laser for those asymptomatic lattice. So what are the evidence and how to prove the efficacy? When I looked in the internet, it was a little bit hard to find resources, not like the previous meetings. They have, the previous presentation, they have a lot of evidence. But unfortunately, when I searched in the PubMed and different search program, I could not find the evidence. I found only very old evidence and very old article published about the issue. So I would like to talk about my own experience in this matter. So let's talk about the cost effectiveness. So there are some cases where we need to do laser for those patients to avoid doing surgery. I'm a VR surgeon. I would definitely enjoy doing vitrectomy in those cases or scleral buckle. But we need to think about the cost on the system and the cost in the medical system and as well on the patient life if they detach later on. So this is the first point about the cost effectiveness. And the other point is it will decrease the risk of retinal detachment by strengthening the area around the hole or around the lattice. But what I really recommend is if you don't think that you will be able to do a proper laser, please do not do it because you might create another holes that will predispose those patients to retinal detachment. So it will decrease the risk of, so there is a certain entity in retinal detachment called subclinical retinal detachment, and there is definition to those cases. If you have a retinal hole or lattice and you start to see a subretinal fluid around these areas, and usually it's from 1 to 2 disc diameter around the thinning, this is an indication to laser this patient. So even if the patient is asymptomatic, by lasering those patients, especially if they are myope, you will decrease the risk of having macula off or macula on retinal detachment or symptomatic retinal detachment. And the other indication is if the patient had a retinal detachment related to lattice in the other eyes, you should laser the lattice and their other asymptomatic lattice in their other eye, because there is a 30% of patients who have retinal detachment also have lattice degeneration. And the other thing as well, if the patient is myope, the risk of having another retinal detachment from lattice in their other eyes, it can reach up to 25%, which is quite high percentage. And if you have a patient going for cataract surgery, I think I would laser those patients because there is already a risk of retinal detachment, and the risk might increase if the patient is myope, patient having lattice, as well for patient who is going to have refractive surgery. So I recommend from 1 to 2 weeks waiting period after the laser to proceed with the procedure. And please do not forget to monitor those patients, because those patients will enjoy the ametropia and they will never come back to you. So I really recommend education for those patients, because they might have another holes or another lattice degeneration, or might come back with retinal detachment. So please keep watching those patients. And take-home message, will you laser or lattice, or there are some entity of asymptomatic lattice that we have to laser? Thank you so much.
Dr. Noura, excellent, and keeping the time. Actually, we have 1 minute to spare, so that's news. Dr. Talwar, please, saying no to laser for lattice. Yeah.
May I have the slides, please? I think Dr. Noura has made my job not only easier, she's actually said that you don't need to laser everybody. So the debate per se is over, but in terms of, is there an indication for not doing laser at all? So we will discuss that.
LASIK assessment. For example, if patients having these lattice lesions, so for all of them you will do LASIK, or some you will do and some not?
Hey, no, I think it's on. So for a patient who's going to refractive surgery, usually it depends on the procedure itself. So I don't do refractive surgery, but always I consult with the refractive surgeon, knowing what kind of procedure the patient is going to go to do, because there are different entity of those procedures. But to be honest, I do mainly for all patients who's going to do refractive surgery, and I always educate, because I did already retinal detachment post-refractive surgery. That's why maybe I might be very hesitant in those cases. So I would do it, but I don't do 360. I do only around the area. So I don't treat the whole retina. I do only where is the lattice or the retinal problem, yes.
So Dr. Noura, you surround the atrophic holes themselves, or you do around the whole lattice area?
So I do around the lattice area. So I don't only do the atrophic hole, I do only around it, because I know there are some people who's doing 360. I don't do this.
So do you see any difference in the type of lattice? Because in my practice, I do not do laser around lattice per se. But there is some entities, because not all lattice are the same. And because sometimes when the label is lattice is a bit different, because sometimes you have lattice on different levels of the retina. They are not just one area of small lattice and that's it. These, in my opinion, I do not really touch. I do not do laser. I keep on following them. I explain to the patient even before or after the LASIK procedure. But for patients with different areas of lattice on different levels, those patients I usually prefer to do laser for them. I do not want to take the time from you, sir.
The moment in medicine you say all or none, the topic is over. Because there is hardly any situation where everything or nothing is treated in a particular way. So today's proposition, all lattice atrophic holes are to be lasered, becomes null and void the moment you put all into it. So all I need to say is, no, not all, some. And this topic is then, it goes in favor of not doing this. The facts are that lattice is an area of focal retinal thinning with vitreoretinal traction at the edges, focal liquefaction of the overlying vitreous, and a tendency to develop breaks at the posterior or lateral edges. So this is the rationale for saying laser needs to be done. Further reasons include the fact that this is one of the most important vitreoretinal abnormalities known to predispose to RD, maybe bilateral in 45% of cases. And lattice is seen in 30% of patients with a retinal detachment. But then, do all lattices need prophylaxis? Lattice is common in the general population, 7 to 8% in the clinical series and 11 to 16% of the autopsy series. So maybe out of the 100 people here, 10 should be lasered. Would we like that huge a number of population to be lasered? The lifetime risk of an RD in a usual patient with a lattice, despite all those tractional forces, is less than 1%. Symptomatic operculated breaks, typically, now we're talking of symptomatic operculated breaks, even they do not typically progress to an RD unless there is some residual vitreous which is adherent to the retinal vessels adjacent. Furthermore, in patients without retinal breaks, that means you have a lattice, you don't have retinal breaks, the risk of RD is very low. And if you have atrophic holes, the incidence of progression even to subclinical retinal detachment is only about 2%, and you can easily pick up a subclinical detachment on a regular follow-up. Furthermore, even despite all those tractional forces we are talking about, retinal tears only occur in about 2.4% of cases of lattice. 97% will not develop tears. Now, even if we talk in terms of fellow eyes, even they are not likely to develop a detachment as a rule. It's only when you follow them up over a period of 7 years or so, it's 2 to 5%. So generally, are we really looking for reasons to treat? Because we've seen something, just like we were talking about topical antibiotics in one way. Well, asymptomatic operculated holes, why I'm saying that? Because you have this statement, asymptomatic operculated holes and atrophic holes need not be generally prophylactic treated, but if cataract surgery is planned, consider. Why? Is it a complicated surgery we're talking about? Is it a phakic patient? We really have no practical basis. So, ladies and gentlemen, where do we have a basis? The basis we have at all is in RD in an untreated fellow eye, because where there is a 5% risk, and in RD in an untreated fellow eye which has myopia with a lattice. These have a high incidence. So this is a situation where there is a merit for treatment. It's not moving. Okay. It's not moving further. Can you move this? Yeah. In myopes with lattice, there is a risk, and specifically if the myopia is more than 3 diopters, specifically from 6 to 10 diopters, the risk is almost tenfold. So this is where, if you have a myopia with lattice, especially if it's in the range of 6 to 10 diopter, there is an indication for treating these patients. I think you'll have to move it from there. Next, please. There's just 3-4 slides left. In a similar thing was found in a study presented in the RO, where they found that in patients with high myopia, there was a higher risk of a detachment occurring, and so there is some merit in treating these patients. Next, please. Now look at this. The American Society of Retinal Specialists says lattice degeneration is a condition that involves abnormal thinning of the peripheral retina. When lattice degeneration is present, the retina is more vulnerable to developing tears, breaks, holes that could ultimately lead to a retinal detachment. When you write so much, I would actually think that they would say, please treat it. But they've said, no, for this reason, once diagnosed, lattice degeneration should be closely monitored. Because of all the facts I mentioned, most patients are not going to become tractional breaks or develop tractional breaks, and so the indication is really not there for treating such a large number of patients for such a small benefit. Next, please. So when should we do prophylaxis for lattice degeneration? Definitely not if you have isolated peripheral lattices or atrophic holes, and even if the myopia is there, if it is less than 6 diopters, they don't need to be treated, they need to be followed up. On the other hand, I would agree with Noura that there is an indication. If you have a patient with associated myopia of 6 to 10 diopters, if the lattices are located posterior to the equator, because the tractional effects will now be much more, perivascular lattices, which are rare, but if they are there, I would consider for treatment, and maybe even extensive lattices which occupy more than 6 clock hours or so. These are the situations where I would consider treatment. The rest, no. Thank you very much. Next, please. I think this is the last slide.
Thank you very much.
May I have another? Yeah, thank you.
Thank you very much, Dr. Talwar. Actually, you stated it very well, Dr. Noura. Okay. You want to conclude? So excellent presentations. I agree totally with you. Not all lattice are the same. Not all lattice should be treated. Once, as you mentioned, post-equatorial or around the blood vessels, or more extensive lattice degeneration, I think those are the cases that I would consider, especially with high myopes above 6 diopters. Dr. Noura, for post-cataract or pre-cataract surgery, so you would consider to do those as well, with any further indications with myopia or for all lattice?
So, pre-cataract surgery, you mean, right? Yes, I would consider, because there is a high risk of posterior vitreous detachment in the first year, and this might be a predisposing factor to retinal detachment.
The best part is that now that you have got an ultra-wide field OCT, so you can study the symptomatic lattice are mainly because of vitreoretinal traction, and if you have a vitreous degeneration where it's floating around, you get symptoms, correct? And if you have a vitreoretinal adhesions which is trying to pull, then obviously that lattice is going to tear. So, Silverstone, OCT, ultra-wide field, you just make a scan, you'll be able to. The paper which is published actually has avoided a lot of lasers, actually included in some of the patients who truly requires a laser. Thank you very much. So we conclude, and it was a wonderful debate, and thank you for all your participation.
Assalamu alaikum, good evening. If you allow me, can you kindly go to the exhibition? So Sheikh will move there for 2 minutes. Then we can go all together to the restaurant there. And we will continue the ceremony in the restaurant. Okay. While we are taking the dinner. Thank you very much. See you tomorrow, inshallah. All the speakers, if there are any speaker for tomorrow, please give us your presentation today. So it will not have this problem like today. Thank you very much.